Welcome to the latest MS Hear from the Experts webinar. This series is helping people better understand multiple sclerosis, highlights MS-related resources, plus provides tools and tips to navigate your MS journey with more knowledge and confidence. Our intention is to help you learn more about this disease, treatments, research, wellness strategies, our programs, and much more. I'm Shauna McKinnon, and I've had MS for a little more than 25 years now, and I'm going to be your moderator for today's broadcast. Welcome to our audiences, including those joining the broadcast on Facebook Live. Now, before we get started with the presentation, I've got to briefly go over a couple of housekeeping items. First of all, microphones have been muted and will remain muted for the entirety of the broadcast. If you do have a question, you can type it into the chat box and we'll try to get to as many questions as possible following the formal presentation. Please note that questions pertaining to specific personal situations likely cannot be answered in this type of venue, and we recommend contacting your personal MS healthcare team or perhaps contacting the MS Knowledge Network for those questions. The session is being recorded and will be available soon on our website in English. We're also adding French subtitles to the recording, but that version won't be available for several weeks. The recordings will be available on our website under archived webinars and on our YouTube channel. A Facebook Live recording will be also available. Also, please note that MS Canada does not approve, endorse, or recommend any specific product, therapy, or service, but provides information to assist individuals in making their own health and wellness decisions. Today's broadcast is an opportunity to learn more about the cognitive changes and challenges that someone with MS may experience, plus strategies to manage and cope with them. Today's expert is Dr. John DeLuca. He is the Senior Vice President for Research and Training at Kessler Foundation, a professor in the Departments of Physical Medicine and Rehabilitation and Neurology at Rutgers, New Jersey Medical School. He is board certified in rehabilitation psychology by the American Board of Professional Psychology. Dr. DeLuca, a fellow of the National Academy of Neuropsychology, the American Psychological Association, the American Psychological Society, and the American Congress of Rehabilitation Medicine. He's been involved in neuropsychology and rehabilitation research for over 30 years. He has published over 400 articles, books, and book chapters in these areas, has edited 7 books in neuropsychology, neuroimaging, and rehabilitation, and is a co-chief editor for the Encyclopedia of Clinical Neuropsychology. He has received over $40 million in grant support for his research from various organizations, including the National Institutes of Health, the National Institute on Disability, Independent Living and Rehabilitation Research, the Department of Defense, and the National MS Society in the United States. Dr. DeLuca serves on the editorial boards of many journals and has received numerous national and international awards in recognition of his work, including the International Neuropsychological Society Benton Mid-Career Award and Division 22's Rehabilitation Psychology Roger G. Barker Distinguished Research Contribution Award from the American Psychological Association. He is past president of the National Academy of Neuropsychology and has served on several other national and international boards in various leadership roles. So welcome to today's expert, Dr. John DeLuca.
Thank you, Shauna. Thank you very much for the kind introduction, and welcome, everybody. I'm very pleased to be here today to talk about a real important topic, and that's cognitive impairment in persons with MS. I have a lot of information. I have a lot of slides, so I just ask you to sit back and just enjoy the big picture. Just get the big picture of what I want to talk about today, and I think you'll enjoy the presentation. So as an overview, I'm going to talk about cognitive problems in MS, what are the key issues that one sees, some of the factors that can affect cognition, briefly talk about impact on everyday life, and what can we do to improve cognitive problems. I'm going to talk about this concept of cognitive reserve, which I think is really important. And if we have enough time, I'm going to talk a little bit about exercise and cognition and medication and cognition. So there's a lot to talk about. So first, let me start from a person with MS. Appointment after appointment, Dr. X listened to my complaints, but didn't take them seriously or relate them to MS. Compared to her patients in wheelchairs, my thinking symptoms must have appeared minor, but they were very powerful and they had the potential to be just as devastating as the physical difficulties. Perhaps some of you have experienced something like this in terms of your work with your healthcare provider. So you all know what MS is. It's a progressive disease that affects the white matter of the brain, also affects the actual neurons themselves, resulting in sensory motor problems, fatigue, cognition, neuropsychiatric issues. We're going to talk about cognition today. And in the United States, at least, there's about 1 million people who are diagnosed with MS, about 2.3 million around the world. Age of onset, on average, is between 20 and 40 years, although people are diagnosed even in their teens or well in their older than 40 as well, but that's on average where you see most of the diagnoses. 2 to 3 times more frequent in females. And the etiology of MS, it's unknown, thought to be an autoimmune disease triggered by a viral infection in genetically susceptible individuals. The truth is, we really don't know what the etiology of MS is. Now, when we think about MS, the father, if you will, of MS is Charcot, who about 150 years ago, when he talked about the symptoms of MS, he said, quote, "There's a marked enfeeblement of the memory and conceptions are formed slowly." So problems with memory and problems with slowed processing speed. He talked about that 150 years ago. But as to turn into this 20th century, and for most of the 20th century, there was a great debate as to whether cognition was actually a problem of the disease itself. And by the 1960s and 70s, medical students were taught that cognitive problems were not a part of the disease. It was something else, not MS. In the early 70s and even early 80s, cognitive problem was thought to be in about 3% of people with MS. We know today that up to 2/3 of individuals with MS have some degree of cognitive impairment. Think about that. 2 out of every 3 patients with MS have some degree of cognitive impairment. That's a far cry from the 70s, where it was 3%. So this is, again, a person with MS. I thought I was losing my mind. It was difficult to explain to others what was happening when I didn't know myself. I do remember the fear and loneliness that went along with all of this. I silently begged God, "Do what you want to my body, but please leave my mind alone." The idea that MS can affect our thinking, our emotions, is really a quite devastating in some way to think about what MS can do. We oftentimes think of its physical ramifications, but today we're talking about cognition. So what are the cognitive deficits in MS? Now, it's important to recognize that MS, of course, is a heterogeneous disease. So there's going to be a lot of variability. But on average, you see problems in information processing speed and efficiency. That is, the way to processing information is slower and less efficient. That's one of the major problems with persons with MS. There are difficulties in learning and memory, which we'll talk a lot about. And executive functions, something that patients often don't understand. Executive functions refers to acting on behavior. So once you've processed information, you can remember it. Can you plan? Can you organize? Can you initiate? Can you start activities? A lot of times the problems are in that area. And there's some also problems in perceptual processing. But interestingly, the newest area of research is in what's called social cognition, or how we understand and deal with other people in social situations. So, for example, there's evidence that persons with MS oftentimes have a difficult time reading the emotion in another person's facial structures. And if you can't recognize the emotion of somebody, it's hard to have your own appropriate response. That's some of the newest areas. We won't be talking about that today. We'll be talking today about primarily memory, learning and memory, and information processing speed, primarily because this is where most of the research is. Now, it's also important to note that the frequency of cognitive impairment tends to increase over the course of the disease. So if you look here at the CIS, even individuals who are not yet diagnosed with MS, about 1/3 of individuals can have some degree of cognitive impairment. When you move on to relapsing and remitting, you see about 50% of these individuals have some degree of cognitive impairment. But look at the progressive forms of MS. 80 to 90% of these individuals have some degree of cognitive impairment. Really important. So there are changes associated with disease over time. Now, I also like to talk about what's spared, what is not impaired. We talk too much about impairment. But what is not really impaired overall on average in persons with MS? And that is basic attention. The ability to just attend to the environment in a very basic way is really not a problem in overall on average. That's good news. Essential verbal skills, such as verbal comprehension or expression, or naming and repetition, are generally, on average, intact. Now, we do know there are some verbal issues. Patients oftentimes talk about word finding difficulties, or I can't find the right word, or I can't express myself like I used to or want to. A lot of that may be due to slowed processing speed. If your brain is slower to really find the words, it may be more of a processing speed problem than a verbal skill. And intelligence, this is really important. I often hear from patients, I'm just not as smart as I used to be. In general, on average, intelligence is not really that much affected. Other aspects of cognition may be. So once again, if you need to do something quickly and your problems are that you're slow to respond or you can't remember as well, you might say, I'm just not as smart as I used to be. But in fact, give yourself enough time, you often can come up with the right answer. So it doesn't really affect intelligence overall on average. So let's talk a little bit about information processing efficiency, because this is the major problem. And I divide this into two: processing speed, how quickly one can process information, and working memory, which is really keeping memory into a short-term buffer for about 30 to 45 seconds. Oftentimes people think about short-term memory as what I've had for breakfast. Short-term memory, by definition, is only memory that you keep in your mind for a short period of time and then you can let it go, such as looking up a phone number in a phone book. You're not going to remember that forever. So, two aspects: processing speed and working memory. So, here's another quote from a person with MS. Often I have 5 to 15 second delay in recognizing what is going on, what is being said, who I am talking to. Don't ask me a compound question unless you want me to shut down completely. One thing at a time and wait. Up until about a year ago, I thought MS would just be a physical battle. So let's talk about processing speed then. Really is a key aspect of MS. So in this study, a series of studies, I'm going to show you what are the odds of having a processing speed problem or a working memory problem in MS compared to the general population. What are the odds of having a problem? So in this first slide, I'm going to show you on the upper left, all MS patients versus healthy controls. And the odds of having a processing speed problem if you have MS is 10 times more likely than the general population. Think about that, 10 times more likely. Working memory is about 2.7 or about 3 times more likely than the general population. So this is an important problem. The other thing to recognize, though, is that processing speed is much more likely than working memory. So again, processing speed is the major component. Now, if we just looked at individuals with relapsing and remitting MS, the numbers change. The odds of having a processing speed problem are 5 times more likely than the general population, which is a lot, okay? But look at working memory. 1.3 is not significantly different than the general population. That means you can keep information in short-term memory, but processing it is much slower. Now remember, we go down to the secondary progressive MS. Remember, 80 to 90% of these individuals have problems with cognition. Look at here. This is pretty devastating. The odds are 65 times more likely to have a processing speed problem than the general population. That shows you the degree of problems in processing speed. Working memory is 9 times more likely, very high degree. But once again, the ratio is such that processing speed is the major issue. And this is really critically important for people with MS to understand what the problems are with their cognition, so then you can help in your everyday life. So, processing speed deficit is primarily the issue here, and working memory accuracy less likely. You can be accurate in your response, but it can be much slower. So what are some of the factors which can affect cognition? Let's go through these very quickly. Disease course, which I've already told you, it's more likely in progressive than in relapsing MS. Duration of disease, yes, as the disease progresses, it could get worse. However, the answer is sometimes. There are some people who are newly diagnosed who have significant cognitive problems, and there are individuals who've been diagnosed for 20, 30 years who have no cognitive problems. So again, it's a very heterogeneous disease. Is it related to physical disability? Not necessarily. Once again, there are people with a lot of physical disability with no cognitive problems, and you have the opposite, persons with cognitive problems and no physical disability. So there's not always a relationship. Fatigue, this is a real tricky one. Is fatigue related to cognition? And the answer to that is usually no, even though one might think that's the case. And we'll show you an example of that in a minute. Depression can affect cognition, but depression is a separate entity in and of itself, which may or may not affect cognition. Same with stress. Gray matter atrophy in the brain, that is loss of neurons, is a very strong predictor of cognitive problems. And gender, well, males are at increased risk for cognitive impairment. Let's talk about some of these factors more closely. The first one is fatigue. So in this particular study, we looked at fatigue and the impact of fatigue on cognitive processing during the course of a workday. So on the left side here, where it says baseline, that's cognitive testing at the beginning of a workday, and then again at the end of a workday. In blue are MS patients, and in yellow are healthy controls. And this is looking at their mean fatigue score. So what you can see is at the beginning of the day, there wasn't really a difference between the MS patients and the healthy controls. But by the end of the workday, you can see in the blue bars increased pretty dramatically, but not the yellow bars. So you're seeing more of an increase in fatigue, a self-report of fatigue. What happened then to cognitive performance? Now we have, again, at the beginning of the day at baseline and at the end of the day, you can see there's actually no change. In very little, not significantly different in terms of actual cognitive performance, despite the fact that patients' self-reported fatigue went way up. So the idea is that fatigue can make you feel like I just can't do anything. But in fact, most of the studies show that when you really test cognition, fatigue is not having the effect that people feel. It's important to understand the feeling. It's also important to understand the influence of fatigue. Let's look at another factor. How about ambient temperature? Temperature around you. This is very interesting. So if you look here on the x-axis, you see on the left side cold weather, and on the right side warmer weather. And this is looking at cognitive status. And what you find is that as the weather gets warmer, patients' cognitive impairments can get worse. And this is a cross-sectional study, so we weren't able to look at the same person over time. However, in this other study, we did look at longitudinal, the same subjects 6 months apart. And even in the same person with MS, during the hot weather, their cognitive scores were lower than the cold weather. So ambient temperature can have an effect, direct effect, on cognitive performance. What about cannabis? That's a big topic. So this is a complicated slide. So let me just tell you, if you look at the green bars, there are two groups, cannabis users and cannabis non-users. On the right, on the left side, there are the cognitive domains: visual perception, executive functioning, processing speed, and global cognitive impairment. And on the right, in blue, it's showing that individuals who are cannabis users have significantly greater cognitive problems than individuals who are not cannabis users. There are no differences on any of the psychiatric variables. This was specific to cognitive processing. So these authors said that whatever subjective benefits that patients derive from using This was street cannabis at the time, but we know cannabis can be now legal. Whatever benefits you can get from cannabis, such as treating pain or spasticity, this needs to be weighed against the associated cognitive side effects. So be wary and think about cannabis and work with your healthcare provider to see if it's going to actually make your cognition worse. And lastly, cigarette smoking. There are a lot, there are too many variables here. I'm just hitting some of the highlights. Smoking and cognition. So we know cigarette smoking may trigger MS. It can facilitate information from CIS to formal diagnosis of MS. It can increase relapse frequency, that is cigarette smoking. Cigarette smoking can promote progression of the disease. And if you look at on this graph here, on the left side are heavy smokers, on the right non-smokers. These are the percent of individuals who have cognitive impairment. Heavy smokers are twice as likely to have cognitive impairment than non-smokers. Smoking is not good for you, period. It's not good for you if you have MS. It's not good for your cognition. So everybody here knows that cognitive problems can affect everyday life. It can do so in a variety of different ways. It can affect employment, driving, social and vocational activities, household activities, financial management, sexual functioning, family activities, quality of life. Importantly, though, beyond the physical disability alone, the cognitive problems themselves can lead to this. And just one example from research that we did looking at driving. We used a virtual reality driving simulator where you can see this person has a head-mounted display looking at driving in 3D environment, in an environment where you can't put patients in where kids are running in front of your car or the car door opens. So what happens in those kinds of situations? What we find is healthy controls in blue and yellow are MS patients who are not cognitively impaired. They didn't differ in performance. But in red, the individuals who were cognitively impaired it made significantly more errors in driving. Now, we didn't stop there. We actually were able to look at patients with the consent of the patient, their actual driving records. And here what you find is in yellow is there are no crashes. In red, there's one or more crashes. Luckily, the frequency of crashes are low. But if you look at the healthy controls and the MS subjects in the middle without cognitive impairment, there's no significant difference. But MS subjects on the right who were cognitively impaired were 6 times more likely to actually have a crash. And this is important. This is not to say that persons with MS should not drive. But the idea is that it can have significant consequences on everyday life. Why assess cognition in MS? Well, cognitive impairment predicts disease progression. Cognitive impairment predicts EDSS progression, which is more physical disability. It predicts a rapid change from a clinically isolated syndrome to relapsing remitting MS. It predicts the progression from relapsing remitting to progressive disease. It predicts the progression within progressive MS. Early cognitive impairment is strongly correlated with cognitive worsening. Cognitive problems are associated with brain atrophy and brain axonal damage, significantly correlated with everyday life, and is associated with poor adherence to treatments. Imagine if clinicians had tests that could do all of this. In fact, we have it. It's called the neuropsychological evaluation. And it's very important that patients know their cognitive status, not only for today, but what might happen in the future. So assessing cognitive impairment, important to know that the neurologic assessment by a neurologist is poorly associated with actual cognitive impairment. In fact, studies have shown the neurologist's judgment is no greater than chance in identifying actual cognitive impairment. What you have to do, so the clinical interview and a neurologic exam is not sufficient. You have to do the assessment. The neuropsychological assessment is going to provide objective functioning as to how you're doing. Well, why don't we just ask the patient, how are you doing? How's your cognition? Well, we need to know how important this is because it's always important to ask the patient and understand what the patients are saying. Our jobs as professionals are to know what the patients mean, not just what they say. And what we know is that patient self-report is poorly correlated with objective cognitive testing, does not necessarily correlate with patients' actual everyday life, but it does correlate with the patient's emotional distress. Patient self-report are talking about how distressed they are about their disease. And that's different from objective cognitive performance. So what about if you go to your clinic, and do patients in clinics get diagnosed? Well, this is a study that's about 10 years old now, but we did a follow-up and didn't change all that much. We find out 52% did no assessment of cognition whatsoever, none. 19% asked just patient self-report, which we just learned is not sufficient. And less than 1/3 did any type of formal testing whatsoever. It's time that patients get the assessment that they deserve to understand the impact of their disease on their cognitive processing. And I present this. This is from the National MS Society in the United States, and they recommend a baseline screening early in the disease. They recommend annual reassessments as well as annual depression screening. And this should be done on an annual basis so that your clinician can know what's going on and how things might or might not change. So with all the problems we just discussed, can we improve cognition in MS? And the answer is yes, a resounding yes. So we published this paper a couple of years ago and found that cognitive rehabilitation has shown consistent beneficial effects for treating cognitive impairment and represents the best approach for treatment, the best. And if you look at the slide here, this simply shows you over roughly a 20-year period, if you look at the dark blue bars, the number of studies that have been conducted over the years, with now over 90 studies, the vast majority showing there's a significant improvement with cognitive rehabilitation. We also found that exercise, although promising, remains preliminary in its work, and I'll show you a little bit of data on that. However, medication, the data is insufficient. There's insufficient evidence to suggest that there's pharmacological treatment to help cognitive impairment. There are a few studies. They're small studies. The effect size is not large. But overall, pharmacological treatment is not the best approach. So let's go and talk about learning and memory, because this is where most of the research is. So through a whole load of research, what we found was persons with MS having a problem learning to begin with. If you're going to take a class, let's say, you have a problem learning, not necessarily a problem retrieving the information that you've already learned. And think about it. If your processing speed is slow and you're listening to a lecture, you might only get 50% of the lecture. And then when you want to remember it, you can only remember up to 50%. But the problem is problem in learning, not in recalling the information you've already learned. If that's the case, then rehabilitation should focus on making sure patients learn. And that's where rehabilitation stands today. And I'm going to give you some examples of this. Very quick examples. I can't talk about 90 studies. But here's something called the spacing effect. We've known about this for 150 years. That if you're going to learn something new, if you space the learning trials apart, you'll remember it better than if you crammed everything all at once, like we did in college. You have an exam on Friday, you can cram on Thursday, or you can study a little bit on Monday, a little bit on Tuesday, a little bit on Wednesday, a little bit on Thursday. We know if you space the learning trials apart, you'll remember them better. So we did a study, and we like to use everyday life tasks. So we had patients read a newspaper article, 2 newspaper articles. One where they read 3 times in a row, and the other one they read spaced 10 or 15 minutes apart. That's the only intervention, was they spaced the learning trials apart. And what did we find? Just by spacing learning trials apart, people remembered more elements of the newspaper article in blue than just by reading it 3 times in a row. Both conditions, they read it 3 times. The only difference was they spaced the learning trials apart. Very powerful effect. And it's easy. It's easy. You can use it in your everyday life. Here's another one. Let me ask you this. If you were going to learn something that's very complicated, something that would take multiple ways of thinking about it, do you want the teacher to tell you this 4 times? Or do you want the teacher to tell it to you once, but then be tested 3 times? And in fact, when people were asked this question, over here in red, you can see when they're asked to study it, people preferred to study it 4 times rather than in green, study it once and be tested. But in fact, what you found was the opposite. when you actually looked at recall, individuals who only were given the information once and tested 3 times learned a lot better than the information given over and over again. And the idea is by the act of being tested, strengthens the information in your brain so you can remember it. Can we use this technique in persons with MS? So here we have on the left side, mass study, studying information over and over and over again. On the right side, all the way into the right, is where they're being tested. They're learning information once and they're tested. And you can see there's a 78% improvement from mass restudy just by being tested. If you look at 45 minutes later, you can see the mass condition, they're only remembering 15%. You're losing that information already. But in the tested condition, they're showing a huge difference. Now they're remembering 77% of the information. That's a huge difference. And what about after 1 week? You're really learning, you're remembering nothing in this mass condition, but a 25-fold increase in remembering that information if you went through and you tested. Now, the idea is these are techniques that can be utilized by a trained clinician. This is the research that shows the clinician that these techniques can work. It's not necessarily something, in this example, you can do in everyday life. In spaced learning, you can. One more example. In this example, this is a clinical trial where it taught patients how to use context and imagery to learn new information. Why context? Well, we've known about this for decades, that if you want to learn new information, if you put them into a context, such as, rather than remembering 10 items when you go to the store that you have to buy, if you put them into a context and say, I have to remember 10 items to bake a cake, that context helps you remember. And if you use imagery, if you can imagine what it is you need to do, you will remember the information better. We've known this for decades. Can we teach persons with MS to use these techniques? Here on the left is the results after the intervention. The treatment group is in red, the placebo group is in black. This is 5 trials of learning verbal information. Pre-treatment, these 2 lines didn't differ. After treatment, there was a 20% improvement in remembering information by learning how to use context and imagery in your everyday life. Here was a study of this result is a quality of life measure. And it's, again, you have baseline and post-treatment. And only the individuals who are in the red line, who are in the treatment group, reported that they felt better in their quality of life. And when we asked patients' families, you can see at baseline there's no difference, and here a lower score is better. The family said, my loved one seems to be better by just a behavioral intervention. Now, we also looked at what was going on in the brain in a subset of individuals. So we put them in the MRI scanner, had them learn new information. So we had the treatment group and we had the placebo group. Before the treatment, there was no difference in activation in the 2 groups. But afterwards, you can see below here with all the red dots, these are areas of increased activation where the persons who received the treatment were showing more brain activity. They're actually showing more brain connectivity. There are more connections with the memory parts of the brain to other parts of the brain. If they had a behavioral intervention, this is not a medication trial. If they learned how to use behavioral techniques, really powerful. What about the patients? What do they think about cognitive rehabilitation? Well, this is a study of about 200 patients looking at 7 different papers across the literature. What do patients say? Patients say they liked the group environment in a group therapy session in cognitive rehabilitation. They felt that the patient's reflection and awareness of their cognitive deficits, they understood it better. Patients felt they had a better understanding of their illness and more knowledge about what's going on with their illness. They used the strategies. They were more effective in using the strategies that they were being taught in rehabilitation. They had more confidence and more perseverance in the way they feel. Patients felt more emotional and social improvements. They felt more alive in their lives. And they had a positive impact on quality of life. Patients with MS like cognitive rehab. The data shows that cognitive rehab works. So this is very important. So cognitive rehabilitation works. It does through neuroplasticity, that is changing brain activity, and it does through changing brain connections. And the studies show that it can even make some structural changes. There's a lot more research to be done. Do these changes actually affect everyday life? And what about longer term outcomes? But Those are yet to come. So let me talk about a very important concept, cognitive reserve. Now, what is cognitive reserve? Now, some of you may know that not all persons with Alzheimer's disease actually have dementia. So if you look at about 20 to 25% of post-mortem patients who have these plaques and tangles in the brain, 20 to 25% of them never had dementia, but they had Alzheimer's disease. Why? Well, there's this idea of cognitive reserve. That is, the lifetime of intellectual enriching activities creates a brain that's more complex. There's increased cerebral complexity. And this complexity in your brain is more resistant to the expression of the disease, not to the disease itself, whether it's Alzheimer's or MS, but to its expression, in this case, cognition. That is, individuals with higher cognitive reserve might have some preserved cognitive functioning. Well, we know that's in Alzheimer's. What about MS? So here we have on the x-axis brain atrophy, low atrophy on the left, high atrophy on the right. Here on the y-axis, we have cognitive efficiency. Remember, that's processing speed and working memory. With low brain atrophy, individuals in the red, high cognitive reserve, and individuals here on this line, low cognitive reserve, don't differ. But as atrophy increases over time, individuals with high cognitive reserve don't show much cognitive change, whereas individuals with low cognitive reserve show a dramatic drop. And that is really, really important because cognitive reserve is something we can actually help develop. So, high cognitive reserve can protect individuals from cognitive decline. So that suggests, can we identify individuals who are at risk? Yes. People who are at risk for cognitive decline are individuals with low cognitive reserve. But more importantly, and I think for this audience today, is can we build a cognitive reserve? Because it could be neuroprotective. So think about it this way. If you're 20 years old and you're in college and now you've been diagnosed with MS, devastating, diagnosis, what's going to happen to my life? A lot of times these patients will drop out of school, become socially isolated, not go out anymore. Exactly the opposite of what we want. We want to build a cognitive reserve, remain functionally active. And that building of the reserve actually can make it so that when the person's 40, they may be less likely to show cognitive impairment. Really important. Cognitive rehabilitation, it works. I'm going to talk really briefly about exercise in MS because I don't know how much time I have left. That my timer is not here. Exercise and cognition. Here you can see once again over about a 15-year period, a lot of work on exercise right now and cognition, exercise and cognition. However, the data right now are not great. And here is data on exercise. And if you look at, this is the classification of evidence. Good evidence is class 1. Not so good is class 4. The dark lines are a negative finding, and the gray lines are a positive finding. You can see that the good evidence is not finding an effect for exercise. If you look at physical activity, which by the way is not necessarily exercise, physical activity could be working in the garden or being active in your house. You can see that there's evidence that the gray shows some evidence, but it tends to be with the poor quality studies. Okay, so the evidence is not great. Same with physical fitness. The studies are pretty good, but they're not the good quality randomized control trials. There are actually none. So the data is kind of weak. However, I'm going to show you very quickly some preliminary data from our work, where we're looking at individuals who are able to use a treadmill, walk on a treadmill versus a weightless control. They're looking at before and after treatment. Individuals who were on the treadmill showed improvements in cognitive processing speed compared to the weightless control. And here, the second study, we had actually a placebo, an active placebo. This was aerobic exercise versus stretching. And you can see that the aerobic exercise actually improved processing speed compared to stretching. And when we did this in everyday life, that is, we had people do exercise in their homes, supervised via remote supervision, a huge effect of improvement in processing speed compared to stretching. So the data is not good so far, but we're really high on this. We really think that exercise is going to have a big potential effect. So not conclusive now, but exercise could help you. You could work with your healthcare professional if you're so inclined to do so. And lastly, very quickly, medication and cognition. Pharmacological approaches, disease-modifying therapies should, in principle, should affect improved cognition. These DMTs, they reduce brain lesions. They reduce the progression of brain atrophy. Some actually decrease inflammatory activities. But the problem is that these studies have suffered from a variety of methodological problems. And when you look at a review of the literature, this one review, and there are multiple reviews, this one said, while pharmacological therapies for reducing disease activity in MS expanded, no effective treatment has been established in the case of cognitive problems. Really not something to be happy about right now. And here again, if you look at the positive studies on disease-modifying therapies, here again, the class 1 evidence, the really good evidence, there are none. The evidence tends to be where there are studies which are not very good with it. For example, they may not have a control group. So you don't really know if they work. So overall, cognitive impairment in 2 out of every 3 persons with MS. Processing speed and learning memory are the primary problems, but there can be other problems such as social cognition and executive functioning. It can significantly affect everyday life. Rehabilitation works. Cognitive rehabilitation can significantly help patients. It's time patients get treated. It's time patients get the treatment they deserve. And building a cognitive reserve is something you can do on your own, working with your healthcare professional. Exercise, maybe. Medications, not so much as we know today. So I'd like to thank you for being here today and acknowledge the many people who I've worked with over the years to really do this work. These are my former students who really challenge me to be as cognitively challenged as I possibly can. So thank you very much.
Well, thank you, Dr. DeLuca. What an informative presentation. I have so many questions myself, but we're going to get to our audience questions first of all. We do have a few minutes left, so you can type your question into the chat box and we'll get to as many as we possibly can. First of all, I'm sure everybody has heard about various brain games that we can do. Is that part of cognitive rehab that we can do on our own? And if so, or if not, what other things can we do on our own to improve cognition?
Yeah, so brain games, really, it's important to note that those are not treatment. It's not rehabilitation. But however, bring back the concept of cognitive reserve. The idea of it remaining intellectually stimulated is really what's important. So brain games can help you with stimulation, but so can reading books. So many times do anymore. Well, because I can't remember things. Well, you know what? Use this idea of the spacing effect that I just told you. Read a chapter and then put it down. Come back the next day and read it again. And then maybe read it one more time. And you will find that you will remember that information. So, okay, you can't read like you used to, but you can maybe enjoy reading again. Play cards. You know how much cognitive stimulation there is in card playing? It's socialization. It's intellectual stimulation. There are all kinds of ways to build a cognitive reserve. Brain games is fine, but remember, it's not rehabilitation. And if you really have a cognitive problem, you have to see and get professional help.
Okay, what types of cognitive rehab are helpful for MS? Like, as a neuropsychologist, do you have to specifically look for somebody with that specialty?
Unfortunately, the answer to that is yes. And part of the problems that we face today is that persons don't have that kind of specialty. They're just not around as much as your neurologist, for example. If you live in a big city, you're more likely to find a person who's able to provide those services. Unfortunately, they're not enough. We are working on research, though, to be able to provide these services through telerehabilitation, through the internet. And there's actually data to support that cognitive rehabilitation can be delivered through the internet. Hopefully, that's going to be something that will be available to patients in the near future.
Sounds good to me. What does research show about multitasking?
Yeah, multitasking, is what we do every day and is really critically important. And I think the major issue with multitasking is coming back to slow processing speed. I think patients are able to multitask, but not like you used to be able to do it before. And that's really maybe related to it's just slower. I can't do this and then do this at the same time because I'm not able to keep things in memory long enough because I'm trying to understand this concept and that concept. There can be some help with that in cognitive rehab. A lot of it, though, is to understand what the problem is so that in your multitasking, you can say, wait a minute, let me get this down first before I do that, rather than expecting yourself to be able to do what you did before you were diagnosed.
That's what I have to do these days, finish the task at hand so I don't forget to do the other one. Is there any evidence that stopping cannabis usage restores cognitive functioning?
That's a really good question. There is data on that. Even just who've been using it for a while, when they stop, they can show some improvement. But remember, it also depends on the degree of cognitive problems you might have to begin with. So if you have no cognitive problems and you use cannabis and it makes it worse, stopping it might get you back to where you were. But if you had, let's just say, progressive disease or severe processing speed problems, and you stop the cannabis, you may still have cognitive problems. So weighing cannabis and working with your healthcare professional to what's best for you is really the best way to do this. There's no easy answer to that.
Okay, somebody is asking about specifically social cognition. What is it? When you were describing it, it made me think of people with autism.
Yes, exactly the case. Were you going to ask something else, or did I interrupt you?
Well, no, just they just wanted more of a definition of social cognition.
Yes. So social cognition is in autism. It's very clear. Patients are awkward in a social context. A lot of times, for example, in the research that we do with autism, when you ask the patients, "Can you tell me, what are your strengths?" A person with autism might say, "Well, I have muscles," because they don't understand the social consequence. It's not that severe in MS, but the example I gave, which is really pretty good research, that in a social context, if persons with MS are unable to read the facial affect of the person you're talking to, let's say it's your spouse, and your spouse is sort of saying something with facial structures that you really cannot comprehend that well, then your response may be inappropriate, leading to a confrontation with somebody else, in this example with your spouse. So understanding that you might be having a problem with that is really important. And the good news on some of the research we've done, and it's very preliminary research, that we can actually treat that. But most people, most neurology clinics don't even know this is the case in MS. It's brand new findings. And I think it's really important for patients to say, I wonder if that's affecting me.
Okay, so that makes me think that if somebody has MS but perhaps also has autism and is affected socially, cognitively that way, how do you tell the difference between whether it's MS related or autism related?
That's right.
But
And, dual
anyway, that's
diagnoses
just
are always
off the top
trouble.
of my head. Okay, another question here. This individual has lived with pseudobulbar effect for decades and experiences excessive crying as opposed to hysterical laughter. Could this be a precursor to other and perhaps more cognitive difficulties?
That's a really good question. Um, I am not familiar with, in fact, if that's a precursor, but I can tell you that it is totally separate. People with pseudobulbar affect, these kinds of problems, may not have cognitive impairment, or they may. So they're separable. Whether having pseudobulbar affect leads to cognitive impairment, my clinical impression is that the answer is no. But there's
Okay.
not a lot of research on that.
Okay, we've got time. Oh, we've got a few more minutes here. Will getting diagnosed at a later age have an effect on how quickly cognitive problems can occur and how fast it can go downhill?
It's a really good question. Um, One of the challenges of being diagnosed later is this due to normal aging or is this due to MS? And that's a real challenge. And there is where you really need a good neuropsychologist to be able to try to tease those out. Um, I will say that just because you've diagnosed later does not mean that you'll progress more rapidly. That doesn't necessarily mean that because, again, they don't always go together with duration or disease activity or with physical disability. So not necessarily, but you do run into that problem of, is it now MS or is it normal aging? Really important to know that.
Yeah, that's one of the things that as I hit 60 this year, I'm wondering the same thing myself. Is this MS or is this normal aging? Somebody is
Yeah.
asking the about learning a second language, and is that going to have an effect, uh, or if that's going to help cognition, and if so, how much does it help?
That's a really good question because there's actually data to support that. So when you think about, again, the broad concept of cognitive reserve, think about all the things you can do to cognitively stimulate yourself. Well, there is actual literature to show that learning a second language can actually help you. It can actually show an improvement in areas of the brain associated with memory. You can actually improve the size of the hippocampus, for example, and you can actually show cognitive change. So yes, second language learning can have a significant impact. Remember though, if you have very severe cognitive impairment to begin with, that might differ than if you had mild cognitive impairment. But on average, that's a great technique to try to build your cognitive reserve.
I would imagine learning an instrument might do the same thing.
Learning an instrument, getting involved with artwork. Believe it or not, there have been studies from our group and others that more socialization actually can improve cognition. Be active, get out there. If rather than saying I'm not going to the movies anymore because I can't seem to follow it, go to the movies. Go see it twice. Do things rather than avoid things. Stimulation is really the key here. And there's data for this. And the patients can actually have a lot of impact on that.
Now, what about stimulation of seeing the same movie two or three times versus novel stimulation?
Both are fine. Both are fine for different reasons. If you want to see the movie twice, it's sort of like reading a chapter of a book twice because if you read it the second time, not just because you've read it twice, if you space it apart, you're going to remember it better. So they're for different reasons, they can both be effective.
Okay. We do have a question about diet and cognition. And does diet have any effect on in cognitive rehab?
There's limited data on that, but the limited data on that tends to be positive. There's not a huge amount of data, but in the general population, there's some evidence that your diet can actually improve your cognition. I don't see why that wouldn't be the case in MS. That was certainly, if you think about putting good things into your brain, it's going to help them better than putting bad things into your brain.
Excellent. Well, we've come to the end of our time for questions. So again, thank you to Dr. DeLuca for sharing your expertise on this topic. Really interesting. I still have many more questions. But as we wrap up today's broadcast, we do want to remind everybody about the MS Knowledge Network, which is staffed by trained navigators who provide consistent quality information and support. And you can connect by phone, email, or live chat through the MS Society's website. All the interactions are confidential. The information is trustworthy. MS Navigators can help you learn more about the programming and resources that we offer. Plus, they can help you find other community or government supports and programs. And they can also get you signed up for the monthly MS Canada e-newsletter. We want you to be part of the MS community, and we encourage you to get involved with our programs, our services, events, government relations, and volunteer opportunities. These days, connecting with each other is more important than ever, and especially as we've just heard from Dr. DeLuca. More information is available on our website at www.mscanada.ca. If you do have questions or you need support for this webinar or any of our education activities, you can reach out to the education team by email to education@mscanada.ca. On behalf of MS Canada, thank you for tuning in to today's webinar. Goodbye.